We would like to welcome everybody to today's webinar that is titled Simple Techniques to Manage the Health of Your Patients with Hypertension. My name is Scott Mash, and as always, I'm here with my partner in crime and good friend, Cathy Costello. With that, I'm going to turn it over to Cathy to get us rolling.
Thanks, Scott. Hi, everyone. Thanks so much for joining us. We've got a lot of information for you today around hypertension, how to diagnose it, how to find it in your electronic health record system, how to go back and search for patients that may not have been correctly identified, and how to put in clinical decision support tools and triggers to remind you of work that needs to be done with patients with hypertension. The last thing we're going to look at is coding for patients with hypertension. Since we're into the new world of ICD-10, there are, of course, new codes that came out last October around hypertension. So we'll look at those also. So what's the problem? Why is it that the CDC decided as part of this grant to include hypertension as well as diabetes as work that is to be done with various sites who are part of the program? And the biggest reason is it is the biggest killer in this country. There are 75 million Americans are estimated to have high blood pressure, which, as you know, is the underlying factor for both heart disease and stroke. And almost half of those, so over 30 million patients, have uncontrolled hypertension. In Ohio, the problem is particularly acute, and this is due to information that we've drawn as a result of this grant, so we know where it's coming from. 56% of all Ohioans hospitalized in 2015 had a diagnosis of hypertension. So pretty significant statistics. So it definitely is a priority matter in Ohio. What the federal government has done when they started, one of the benefits of the electronic health records is it's given us a lot more data on what's going on in population health. And when the realization hit with how large the numbers were of hypertensive patients in the country and the impact it was having on our health as a country, CDC, the Center for Disease Control, in conjunction with CMS, came together to create what was called the Million Hearts Program. It was a 5-year initiative to try to better educate providers in working with patients with hypertension and hopefully to reduce the number of heart attacks and strokes that occurred during that period of time, and the goal was to reduce them by 1 million patients. So we are now this program started in 2012. We're technically in the last year of it, but the hope is that the tools that were produced as part of Million Hearts will continue to be used in practices in working with your hypertensive patients. So one of the parts of Million Hearts that I think says it all is the concept of hiding in plain sight. The fact that there are so many hypertensives that are out there that we just have missed. So we're going to look at that. And the Million Hearts program is expanded to 2022. And so we are going to continue to work on the training for it. And before we start going into the coding and finding of the patients and how to use the EHR, just a little reminder in case you have not had the opportunity to look at the Million Hearts website in a while. I know some of you have actually participated in the program. I would suggest going to the website because they are constantly pushing more information to it that you can use both yourselves as providers, but also use as patient education pieces. And there are many tools and protocols that are good to be adopted. And Cathy Rich would never forgive us if we didn't talk about her favorite reminder, because she loves to look through and look for patient-facing things that will improve the care. And she came up with, if you look on the right side of the screen, something that was put in, I don't know if it was Million Hearts that had promoted this, but it was an example on one of the blogs where a practice had actually purchased little heart-shaped magnets, and when they have patients that had elevated blood pressure readings as they came in for an appointment, they would put the magnet on the door of the patient before the patient is seen by the provider. Again, you know, in the simplest terms, this is a form of clinical decision support. But as you all know, we learn in different ways, and sometimes visually, something right in front of your face, something that is different than looking at a computer, may be the best reminder that you need to look at that more carefully and make sure that there's a program for that patient. Here's some reference sources, and as you can see, OACHC and their national association are also part of Million Hearts, as is the AMA, AMGMA, and the AAFP.
Yeah, and on the Million Hearts page, you'll actually find some documentation specific to a few EHRs. I believe there's some next-gen documentation, some Allscripts Sunrise documentation that will show you how to generate reports or how to set up a CDS rule for some of the EHRs, just to kind of give you an idea of what you may want to do within your own EHR to help support your Million Hearts initiative.
So, as we had said, we're going to go back to the concept of hiding in plain sight, because I think there's a common belief that people who are hypertensive are ones that are not taking care of themselves, that they just aren't going to the doctor, they don't care, you know, they aren't watching their diet and everything else. And nothing could be further from the truth. It is estimated that the majority of patients with hypertension that are undiagnosed have actually been to see the doctor. And they have in medical insurance. These are not people who are uninsured, who are not receiving care. These are people that for one reason or another have slipped through the cracks. So they are, in essence, hiding in plain sight. So what we're hoping today is to show you how to go back and capture those people, and then looking forward how to more effectively use the electronic health record system to ongoing capture your work with hypertensives and to make sure they are being correctly diagnosed. First of all, to identify the problem, and you have to love the medical world, because if we do anything well, it's like breaking everything down category by category by category. And the funny thing is about blood pressure readings is when we were back at ICD-9, and we're going to look at the ICD-10 codes here in a second, but when we were back at ICD-9, all the various iterations of hypertension had really gotten to a huge number of categories. I think they were up around 9 or 10 different codes that could be used for hypertensives. And what they did in ICD-10 is like, oh, we're going to simplify it. We're just going to go with normal, at risk, and high, and that'll cover the field. And once you know it, that ICD-10 came in, what, a year and a half ago? By last October, so a year after ICD-10 was introduced, CMS came forth and introduced 3 new codes for diagnosis of hypertension, and that is hypertensive urgency, hypertensive emergency, and hypertensive crisis. But honestly, as an EMT told us that deals with heart attacks and strokes a ton out in the field, he defies you to find many providers that when you get a patient whose blood pressure is up over 200 is going to make that fine distinction between whether they're urgent, emergent, or in crisis. In any case, those patients need to be addressed immediately and need to be in the hospital. But for what you're trying to do, the reality is we're going to be dealing with one of these first 3 categories, that we're going to be looking at patients who are normal that you're just going to want to be monitoring them every time they're in, making sure you have a blood pressure reading on them. Those that are at risk where they're elevated, but not to the level that you'd be concerned about hypertension, or you don't have more than one reading on them. And then those that are high. So when you go back and categorize people, these hiding in plain sight patients, these are really the categories you're going to be dealing with. Any of the other ones, the more severe ones, are ones that you would have already sent to the hospital. The coding for hypertension, as I mentioned, has become in fine form, has many codes attached to it now as opposed to the 3 they originally had planned. But the whole idea is to use the code to tell the story. So when you need to go back, I mean, clearly you do it for billing purposes, but excuse me. The other reason you do it is to make sure that you are accurately documenting within your EHR system what the patients are about, what it is that is the problem, so that you can go back in and pull that information, create patient lists for patients who appear in certain categories. And let's look at that to see how you would use these codes. Clearly, the first 3 categories are ones that you should have on every patient. You should be listing age, sex, and their BMI score, because that in and of itself is going to impact your analysis of the patients with hypertension. Now, the essential hypertension, which is really where most of, as I said, most of these hiding in plain sight cases, as you go back to make sure you're correctly coding them, are going to be diagnosed with this, I-10. So you're looking at a circulatory system disease, and then you're looking at how to break that down. So I-10 is basically essential hypertension. What you need to know, though, is sometimes you're going to have patients that don't rise to the level of true hypertension in the classical sense, because you get in the question of whether there was more than one reading, whether they had more than one visit. But for whatever reason, this patient had an elevated reading, you're concerned about it, but you're not sure that you're ready to actually categorize them as hypertensive, whether you're concerned about a white coat syndrome, the patient is just anxious because they're in the physician's office, or whether there's a situation that has caused the hypertension, or whether you really need to truly have this patient back in and check them a second time. For whatever reason, you want to, don't let them go without coding that, and coding it as a R03, so that you know that there was something abnormal or elevated, and that you can go back and, using that code, pull that patient back in and look at them again and decide whether or not you need to code them as hypertensive. Then when you go beyond that, let's say that you have actually identified them through more than one reading that they are hypertensive. Then you're going to be more specific about what other condition is impacting that hypertension. So the 11.0 series are those with and without heart failure. 12 is with chronic kidney disease, which is actually if their end-stage renal disease are taken out of the quality metrics for hypertension, but you still need to code your patients. And then the I-16 series, which, as I said, are those patients that you probably sent over to the hospital as soon as you got a blood pressure reading of 260/140. Okay, so looking within your system, and Scott has really done a beautiful job in mapping this all out, and he's going to walk you through step by step. But basically, just so you understand where some of the problems come from, and it's not that your practices are not doing an excellent job. They are, and frequently the information is documented within the record, but because of the way electronic health records capture data, it may be data that is not flowing back into a quality report that allows you to pull a patient list. So just to explain that, you could have, and this also depends on the type of electronic health record system, because each one captures blood pressure a little bit differently. But if your providers are free texting, where the systolic and the diastolic pressure are basically being manually entered, that may not be captured within your quality report, but it's necessary that you find that information. And the second reason that you may be missing these patients is, depending on how the quality report is set up, technically it's supposed to be patients who have been seen twice with elevated blood pressure and not coded for hypertension. So whether or not the 2 times have been met or whether the coding is lacking, these are the areas that really create the issues about where these hypertensive patients can be found in your EHR system. Steps you want to take as you're trying to determine how to use your EHR system more effectively, and excuse me, and how to find the missing patients. First of all, this is a process, and it is a process that is based upon your particular site, your particular patients. You're going to know if there's, you know, a certain composition of your patients that you're concerned about, or there's a certain occasion where you want to be more specific. So let me look at this. You can either look for all the undiagnosed patients, or let's say you're coming up to a specific health month where it's heart attacks or strokes or, you know, whatever. You can look for patients who have that underlying condition and then look for the hypertension related to that. So you're trying to tie it into a message to the patient population. You can also, let's say you have a Women's Health Month that you're doing, or you're sponsoring a women's health fair. Well, you may want to go back into your system and look at the women between certain ages that you're going to be helping at the health fair, and really try to gather more information on your particular patient population, given that particular you know, group of patients, by age, by sex, or whatever, or the classic one, the smokers versus non-smokers, just so you have a better idea of how much crosswalk there is between some of these chronic conditions and your missing hypertensive diagnosis. The second thing you want to do is determine the filters that you want to use in creating your report. And Scott's going to walk you through setting up those reports, but there are certain things that you're going to want to decide, whether you're looking at the overall hypertensive population, you're looking at certain age, certain sex, certain date range. Date range is important as it pertains to other reports you do. So for example, some of the reports go back 3 years, some only go 2 when you're, for example, doing your UDS report and what's being captured. So you want to be sure that the date range reflects whatever report or whatever patient population you're looking for. Technically, to diagnose a patient as hypertensive, you want a patient with 2 elevated blood pressure readings within the past 12 months. But as we mentioned, it may be more beneficial for you to look longer ago than 12 months, because if they may have a history that you want to be following, get them back in and check for another elevated blood pressure reading before you code them for it. But if you do have 2 elevated blood pressure readings within the past 12 months, technically you should be changing that code to hypertension, because the reality is that no EHR system is going to pull a quality report unless the condition appears on your problem list and is diagnosed as a diagnosis code that appears on the problem list. So it is really important that if you can find these patients that are sitting in your EHR and you have identified them as ones that have 2 elevated readings or that have 1 that you need to check on again, you want to go back in and make sure that that is coded on their diagnosis list, because if it is not, you're never going to be able to recapture that as part of your patient registries on hypertension. So please make sure that you take the additional step to go back in and code them once you've identified them. And just as a reminder, I-10 is the essential hypertension, 11 is with heart disease, 12 is with kidney disease, and then 13 is with all 3. And with that, I'm going to turn it over to Scott so that he can talk about how to use your EHR to create some of these reports.
So we're going to take a look at an example using the Allscripts Pro EHR ad hoc reporting tool. The reporting tools across different EHRs, you're going to find a lot of similarities between Allscripts and NextGen. Unfortunately, Greenway's a little different, a little more difficult, doesn't have quite as many options, but every EHR you're going to see some variance. And so again, we're going to look at a simple report in Allscripts using the ad hoc report tool. So within Allscripts, we're going to go to the reporting module. The one thing I like about the Allscripts, well, there's many things I like about the Allscripts reporting module, but the first thing it has you do is define your segment, which is pretty much your patient population. Who do you want to look at? They deliver a large number of these predefined patient segments. Thankfully, one of those is 18 to 75, which is actually the matches the criteria for the clinical quality measure for hypertension. So we're going to select that segment. When we do, it pulls up the segment to allow us to make some tweaks to the criteria. So let's say you have a Women's Health Month that you are going to promote. We could add sex in here to say that, you know, sex, the female sex. So then these preloaded patient population would be even more narrowed. But in this example, we went with the 18 to 75. So once you see this display, if you want to make no changes, you just click OK. And then we want to tell it to execute. Really what it's saying here is, hey, let's preload that patient base. We're going to layer on some more criteria, but this patient base is going to be ready for us to use. So now we're going to click on the green arrow, or green plus, because we want to add more segments. We want to add more criteria to this report. So when we click on that, then we're going to see a display for your criterion. We want to go to vitals, because what we're going to do is we're going to identify our our patients with a reading of 140/90 in the last year that do not have hypertension on their problem list. So the first thing we're going to do, now that we have our patients loaded, we're going to go to vitals. Allscripts breaks up the systolic and diastolic into 2 separate segments because they are keyed in separately. We're going to select first the systolic with a relative date. The relative date's really important, and I'm going to show you why. Because once we click on that, it's going to say, okay, what do you want to look at? Well, we want to go 1 year in the past. So 365 days in the past. I look back of 1 year. Well, what are we looking for? Well, we're going to select greater than or equal to 140. If we were going to look at a risk, we could say between 121 and 139 here if we wanted, but in this example, we're going to look at those that are have a greater than 140/90 in the last year, and just a single occurrence. So we're going to set that, and we're going to click on the OK button. We're going to add another criterion. Because we have the systolic, we need the diastolic as well. So we're going to select diastolic with relative date. Same thing. We're going to set it up to look at 365 days in the past, and this is current date. And we're going to look for the diastolic measure of greater than or equal to 90. Now, it's going to show us these criterion within the window or within our reports property window every time. Now, we're going to add yet another criterion, because if we ran this right now, it's going to show us every patient with a 140/90 without respect to if they do or do not have hypertension on their problem list. So we're going to select that. We're going to click that green arrow one more time. This time we're going to drop down to diagnosis. Now, all scripts within their reporting tool, they haven't renamed that ICD-9 to just say ICD or ICD-10. So we're going to look at the active problems during the encounter. Ignore the ICD-9. Now, we want to make sure that we look for patients who do not have hypertension on their list. So really what it's asking for us to do here is, what problem do you want to search for? Well, we want to search for hypertension. We key in hypertension, we click search, it shows us all of the conditions with the word hypertension in them. We can simply click check all here, though it is important that if we do click check all, we scroll down until we find that R03.0, which is elevated blood pressure reading without a diagnosis of hypertension. We want those people to be selected, so we would uncheck that. Now, here I am, I'm saying, well, we want to find all of our patients without hypertension, yet here we are selecting hypertension as the diagnosis we're looking for. Well, once we click OK and we go back to this screen here, the Criterion Properties, we're going to click this mark negative. In other words, what we're saying here is, rather than searching for all the patients who do have hypertension, those hypertension conditions that we selected in the previous screen, we want to find those patients who do not have any of these conditions that we've marked. So that's why we want to uncheck the R03.0, elevated hypertension without, or elevated blood pressure without hypertension. But at any rate, now we have all of our criterion selected. We're going to go back to our reports properties page, where we will give a title to this report. You'll see here that our segment is highlighted, or actually our segment, we want to make sure that it appears, this active patients 18 to 75 appears in the drop down, because we preloaded that segment. Now, this keep for is really you're defining how long you want to keep this report within your system that we've just defined. In this example, we set it to 365 days. So it's going to keep this report with all of the criteria, with all of the patients within our system for 1 year. And once we've ensured that all of our settings are correct, we're just going to hit the OK button down in the bottom right-hand corner of the screen. Once we click OK, we're going to get, it's going to ask us if we want to execute that report. We do want to make sure that we click display results, because why would we want to run a report where we're not going to display the results?
You never know.
You never know. But you can see in the top section of the execute report, the segment. We're looking at active patients ages 18 to 75. We can see that there are 14,000 patients who meet this single criteria, and from which our additional criteria will be ran. So we're going to hit execute. We get presented with a really nice list, and this is an active screen here, so we could click into the patient to see more information about the patient and pull up their chart, or we could also just print it. We can export it. But this will give us our list of patients that are potential hypertensives, but yet do not have hypertension on their active problem list. So with that, I'll turn it back over to Cathy for a few slides.
Okay, so a few categories that we're going to want to be specific about, and I think Scott showed you how to set up the reports to find at-risk patients. These are ones that may not technically be hypertensive yet, but ones that you want to keep your eye on. And I would say that there's two major categories here. One is patients who have only one reading but are greater than 140/90. The second is you may have had two blood pressure readings but they both are running in that 120/80 to 140/90. So at risk, you're concerned. It's one of those things where maybe you want to have that patient come in more frequently than once a year to verify whether or not they are truly hypertensive, so you can consider what your care plan is going to be for them. In this one, you can also, what I'd say is exclude the ones who are RO3 in their coding, because those are ones that you've already recognized as having elevated reading and you're going to already be following up on them. The second area is how to work with your hypertension ECQM measure. So this is the one that we all have gotten to be so familiar with, the NQF 0018 or CMS 165. And this is the controlling high blood pressure measure that basically tracks the patients who are have been already identified as hypertensive within your system. You've already coded that as part of their diagnosis, and the numerator is going to be the patients who are less than 140/90. So ones that due to medication, due to nutrition, whatever reason, due to exercise, are showing as well controlled in their last blood pressure reading. So that's what the ECQM pulls, is the denominator is all your hypertensive patients, numerator are those that are under control. Well, what is it that you can get out of that report? If you run that report and sort and put your numerator patients, those under control, in one category, the rest of the denominator are going to be those that are out of control. So it's very easy by running your patient list based upon your ECQM for hypertension to establish patients that are already hypertensive but that may need further guidance or a change in medication or whatever, but it gives you a quick and easy way to basically find that patient population and to work more intensively with them. And with these are what I would call the non-compliant patients. These are the ones that if you mark negative when you're running your report, as Scott was showing you, it will pull those patients out of the denominator who do not meet the criteria for blood pressure under control. So with that, I'm going to turn it back over to Scott so he can talk to you about how more effectively to use your EHR system to make it more functional and create better reminders for working with your hypertensive patients.
So the ad hoc report that we created earlier is a great tool that's going to allow you to kind of look back over your patient, to kind of do some planning on how to address those patients who may be, should be considered for essential hypertension. But the clinical decision support rules are something that kind of is more proactive. These will, for the most part, present at the at the time that the patient, during the encounter, to maybe say, hey, consider this patient for hypertension, or provide shortcuts for tools to treat those patients with hypertension. So within most EHRs, the triggers for a CDS rule, a clinical decision support rule, are your demographics information. The demographics, the age, the race, the sex of the patient are critical at the when the patient's being received or entered, keyed into the system, that information not only be there but also be correct. Family history can be a driver for some of these CDS rules. Problems, huge trigger. Huge trigger would be your problems, your meds, your blood pressure readings, or any of the other data points that you key in throughout the clinical visit. Now, it's also important that your CDS rules present to all members of the care team, including your reception staff, your support staff, your nursing staff, the providers. everybody should be presented with these triggers. Now, it is critical that you not create so many CDS rules that you then have alert fatigue within your care team. You want smart CDS rules that I always tell folks, set up your CDS alerts such that they protect you from your worst day. Imagine you have a terrible cold, you don't want to cancel your patients for that day, or you just can't afford to take off, so you take some cold meds, you go to work, and you're just driving through the day. On that day, what is it that you could miss? Develop your clinical alerts, your CDS rules, such that they fire for those items that you might miss during that worst day. So back into the Meaningful Use program, early on, we all thought of a CDS rule as those alerts that pop up and kind of jump out at you and stop what you're doing in the middle of a workflow. Well, that concept or that definition of a CDS rule was expanded to include just that, those alerts that stop you, but also to include clinical guidelines, order sets, focused reports, documentation templates, and other items within your system. But we're going to kind of focus on those alerts that pop up for you to kind of stop what you're doing and maybe get you to consider something else. So here's a good example of a CDS rule. You've got a patient in the office. They do not have hypertension on their problem list, but they have 2 blood pressure readings of 140 over 90. So you get an alert. It pops up to somebody on the care team, in this case the physician, that says, hey, let's look at the chart. Let's slow down. Let's see if should we consider hypertension for this patient. So it just is a quick way when they pull up a patient in context, they'll get these alerts, just kind of little reminders or stuff, to consider throughout the visit. Now, problem-based order sets, we said those are considered a CDS rule, but it's a little bit different functionality. Think of the problem-based order sets within your EHR as a replacement for the good old days where the providers had a stack of printed paper orders. Let's say they would have one for hypertension or one for diabetes that they'd pick off the shelf when they went into the room so they could just make a couple quick check marks to order some tests or order meds for that patient. Well, really, that's what a problem-based order set is within the EHR. It's just a shortcut to commonly used lab tests, radiology tests, medications, or even educational material. It just puts it in a nice logical grouping for the provider. Generally, these are defined by a specific diagnosis. They can be defined by a population. It just really depends on your EHR. And again, they're designed to save you a few clicks. So an example, a real-world example of a hypertensive order set. Maybe you've got a section within your order set that are the commonly prescribed meds. A lot of order sets will allow you to even do groups within a group or subgroups, so that you'll have a medication group, and within that you might have the group of diuretics that you could click on and expand the diuretics or beta blockers, ACE inhibitors, whatever. Then you'll have a section with the test, a section with the patient ed, and you can even do referrals in a lot of the problem-based, and maybe there's a referral to a self-management program. And some EHRs allow you to get really crazy, and you can do you can include a lot of other information or a lot of other items within your problem-based order sets. Now, this is another real-world example. This is, I believe, from Allscripts TouchWorks, where they've defined, you can see here in the upper left-hand corner, there's an active problem where we've selected hypertension, and you can see here that this care guide, as they call it within Allscripts TouchWorks, is very long. All we're seeing in the lower right-hand corner is the medications group. But you can see that they have it broken down, so they have subgroups for diuretics and beta blockers. And if we were to scroll down, they would have under the lab test lipid panel and maybe a few other common lab tests. But all the provider would do is they would scroll down through this list, check what they wanted, and hit submit. Now this saves a lot of time because now you do not have to go to the your ERX workflow, search for a Atenolol or search for the lab result or lab test that you want. It's just a few clicks and boom, you hit your submit button. Another tool that's you should really consider using within your EHR, not only to get the patients in for a scheduled exam, but also to engage your patients between visits, is patient reminders. Now, the patient reminders, with most EHR, these reminders will go to the portal. Some EHRs do have an add-on functionality where they can do the automated calls or do some texting. You got to walk a fine line there with HIPAA, but those functions are available in a lot of EHRs. And again, remember, the reminders for an upcoming appointment are critical. You want to make sure that you have as low as possible of no-shows as you can, get those patients in here. But also think about the engaging patients during Hypertension Awareness Month, or during your Women's Health Month, or whatever, flu, when flu comes around. Push those out. Get folks used to logging into your portal. When they log into your portal, they just might click on some educational material. Maybe they'll think, hey, I'm about out of my meds while I'm in the portal. I might as well send through a request for a refill, or I forgot to tell my doctor something last time I was in the office, so they can send a secure message. So this is a critical tool in engaging your patients between visits. Keep them engaged, keep them thinking about their illness, so maybe they'll do a little better job of managing that illness. Now, each EHR sending the reminders is a little bit different workflow. This particular screenshot that we have up here, off the top of my head, I can't remember which EHR this is from. I want to say this might be NextGen, but at any rate, you can go in with this one. What we're setting up is a patient call reminder that will then be sent out to their automated call system. We can define one patient, we can define a list of patients, we can click OK, and boom, the magic goes out and all the patients are called. Now in this example, and I believe this one is from Allscripts Pro, you can define through logic, which looks very similar to the query logic that you would use for an ad hoc report tool, of who you want to send this to, narrow down that. Now in this example, this is showing a mammogram. We could very well say sex is female, age is 18 to 75, and they have, we'll say, hypertension on their problem list, and they've not been in the office for the last 12 months or last year. This would send that reminder out. We can say, hey, you have hypertension. We haven't seen you in a while. Give us a call. Let's get you scheduled for an exam. You can get very detailed with the criteria, get a very focused group, or you can get a very wide group. Now this is an example from MedInt. What MedInt allows you to do is first run a query to define your patient list. So you can get real crazy on this one. You can say, you can set up a patient list that is just your females ages 50 to 75, because let's say maybe you've got a health fair coming up that's just focused on that specific subgroup of patients. You could pull that in, send a reminder out, or send a message out that says, hey, we've got a health fair coming up. But at any rate, within MedInt, you first define your patient list, and then you define the message that you want to send out. So that's just a couple examples to get you thinking about what you can do within your EHR. Again, every EHR is different. Weigh the impact of having too many alerts, but leverage that ad hoc. Well, first, leverage your built-in reports. Most EHRs will have a huge number of built-in reports. Don't waste time recreating the wheel through the ad hoc report tool. See what's delivered. Then consider your ad hoc report tool for pulling in a very specific group of patients. And again, that's kind of a point-in-time look back or point-in-time for planning. Think about your CDS rules. Don't overdo it. Don't get too many alerts going on. Hit the high notes. Hit what's really, really important while the patient's in the office. And then consider how you can leverage other technology within your EHR, like patient reminders, like secure messaging, to engage patients between those visits. with that, so Cathy, we have no questions.
Okay, well, thank you all for joining us. We really appreciate it, and you can certainly let us know when we're out at your site or in any of our calls or emails if you have any questions on this. So have a great day and enjoy the weather.
Now, when you do close out, you're going to be presented with a survey. Please take the time to fill out the survey because we do look at every one of those responses as a means to improve future webinars. So again, thanks for attending, and we'll talk to you all later.